Welcome to the ILS Crash Course. This session basically is a session that we usually go through before the practical session. So if you are listening to this, there will be a practical session that follows. As usual, we have the following learning objectives. As this is a session for the CP3 medical students on critical illness attachment, the A to E assessment would usually be covered in a trained sim day. During the session, we would have an airway session with those learning objectives, and there would be a CPR station as well. But before this, we'd like to go through a case scenario which builds up the context of ILS. An F1 doctor will usually be faced with cardiac arrest, invariably on their rotation through a hospital rotation, for instance. And this case scenario you would describe a cardiac arrest situation. There's a bit of warning on this. It contains 12 pre-test questions that you'll be required to either go through as a group or work through yourself. You may want to get a pen and paper and make some notes, or you may just work through with us as we go along in this case. So, you're the F1 doctor on hospital at night and it's 2 a.m. in the morning. You're about to take a break in the mess when suddenly your bleep goes off. Fibrio, you remember the name very well. You are on call on F22. Fibrio, 25-year-old top footballer, has become unresponsive. This chap had a knee operation which went successfully well 3 days ago and was starting to recover. So what is going on now? Fibrio has suddenly become unresponsive. You get out of the mess and you run on the corridor of your hospital. You run towards F22, which is on the 4th floor. You're almost catching your breath and losing it at the same time. But then you arrive on the ward, and first thing you do is you want to be sure of what's going to happen next. What is your approach to this patient first and foremost?
So, thinking about 3 S's, you should check that it's safe to approach the patient. You should speak to the patient, shout to him and see if he's all right, and then shout for help if you are concerned.
So you're sure it is safe to approach, and so you approach Fibrio and you call out to him and say, "Are you all right? Are you all right?" And he doesn't respond, and you immediately shout for help. In this case situation, you shouted for the sisters around you in the ward. You shouted for your colleagues who are around you. And you also made sure someone dialed 2222 to call for help. Or you may want to use the doctor's ABC, which is the DRS, danger, response, shout for help, and then ABCD assessment. You do all of this and Fibrio still doesn't respond. You place him in a position you normally would do to check for signs of life. So how do you check for signs of life?
So you look, listen and feel for approximately 10 seconds. You are looking for chest movement, you are feeling for a carotid pulse, and in pre-COVID times you would be feeling for breath on your face, and you are also listening for any respiratory effort.
Pretty useful to know that you're wearing PPEs at this stage, and so you would not be able to feel the breath of Fibrio on your face. But with all of this, it still doesn't respond. And then you begin chest compression. You try to measure with 2 fingers, and it's too well built for you to measure. You can see his nipples, which you can see very clearly, and you place your both hands in this manner, claps together at the center of his chest, and you start to compress. And you compress hard and fast with a depth of
5 centimeters, a rate of approximately 2 per second, which is 120 beats per minute. This is 30 times, and you stop to give 2 rescue breaths.
And you do all of this thinking, he's going to respond, I hope he's going to respond. But then you need to do more, because this is ILS, you need to do more. You need to place some defibrillator pads on this patient, and then this rhythm comes up. What is this rhythm, you ask yourself? What is this rhythm?
So this rhythm is PEA.
So, you see what appears to be an electrical activity. There's P waves, there's QRS complex, there's T waves, but then there's no pulse. Yes, that must be a pulseless electrical activity. The question then is, to shock or not to shock?
You don't shock.
So you don't shock the Fibrio, you carry on chest compression. You continue chest compression for 2 minutes. Now you consider what could have caused this. You're thinking through your mind and few things come to your mind. Is I had a knee surgery 3 days ago. Did someone cross up that enoxaparin? What else could be going on? What has happened in the process of me going to the Met and coming back to this gentleman? Surely something's going on. And you start to think around 4Hs and 4Ts and all the things that you could consider: hypoxia, hypothermia, hypokalemia, hypovolemia. You think around tamponade, tension pneumothorax and thrombosis and toxins. Question is, which one is your top differential?
So my top differential in this case would be thrombosis in the form of a pulmonary embolus.
So in your mind, you start to think, how do I treat thrombosis in this case? But you still carry on chest compression because then it's still not at that point yet. But you're thinking this could be thrombosis. And after 2 minutes of CPR, you do a rhythm check like you normally would do. Somewhere along the lines, you're giving some adrenaline and someone shouts out, "Let's shock this. Let us shock this." And you are the team leader. You're looking at this rhythm. What is this rhythm? And do you agree to shock?
So this rhythm is ventricular fibrillation, and I agree that this is a shockable rhythm.
So what are the things you're thinking of before shocking this patient then?
So we need to be clear in our commands that we are giving. We need to ensure that the CPR is uninterrupted for the shortest amount possible, and we need to deliver a shock safely to the patient.
You deliver a shock, and what you do get is you deliver the first shock and the second shock. You keep getting this rhythm. You deliver a third shock, and you start to think at this point, these is 3 shocks already. So after 3 shocks, what drug or drugs would you administer and at what dose?
So at this point, 300 milligram bolus of amiodarone should be administered.
You do give the amiodarone in this case, and you start to think of another point where you may need to give amiodarone again, which is a dose of 150 milligrams that can be given following 5 defibrillation attempts if a pulseless VT or a VF persists. This is not recommended for use in a non-shockable rhythm. At this point, you start to observe Mr. Fibrio, and he has a return of spontaneous circulation. Now you can take a breath in and out. But then you're still thinking, I'm still not done here. What 3 post-CPR investigations will you do?
So we would do an ECG, a chest x-ray, a full set of bloods including a venous or an arterial blood gas.
That'll be helpful for the destination of where this chap is going. The Fibrio is transferred to ITU and you return to the mess. And you're thinking, what just happened? Which is cardiopulmonary resuscitation. Welcome to ILS Crash Course.
Good luck.
Around possible causes of patients, that deterioration in patients, so things patients can come in with that can invariably lead to cardiac arrest. And the next session we'll be looking at airway management and CPR